Picture this. It's 2 a.m. in the ICU. Your patient was stabilizing, but suddenly alarms are flashing red everywhere. Their mental status is deteriorating fast. Platelets are tanking. We're talking 45,000 down to 12,000, and their LDH is absolutely skyrocketing. You're literally looking at a patient whose microvasculature has turned into a thrombotic war zone. But if you try to put an IV in them, they'll bleed profusely. Welcome to this high-yield medical explainer. Today we're demystifying the life and death cascades of blood hemostasis. Forget the oversimplified diagrams you saw in undergrad. We're mastering the complex, real-world physiological cascades you actually need for your board exams and critical care rotations.
So it begs the question, right? How exactly does a patient bleed out while simultaneously clotting to death? I mean, it sounds like a total physiological paradox, but it's a terrifying reality on the wards. To solve this, we can't just memorize a list of symptoms. We really have to understand the fundamental rules of blood volume regulation, vascular tone, and exactly what happens when that super delicate balance fails.
Here's our structural roadmap for the explainer. First, the big picture. 2, a deep dive into the mechanisms. 3, the pathology of TTP. 4, the pathology of DIC. And 5, the expert takeaway.
Let's start with section 1, the big picture.
When hemostasis works normally, it's an incredibly beautiful and localized survival mechanism. You've got this secondary fibrin meshwork. It's like a dense fibrous net, and tangled right within it are the platelets forming the primary plug, along with red blood cells caught in the web. The ultimate goal here is an efficient, rapid, and most importantly, strictly localized response to stop bleeding. It all kicks off with vasoconstriction to reduce blood flow, followed instantly by this highly coordinated interplay between the endothelium, the platelets, and your coagulation factors.
Moving on to section 2, deep dive into the mechanism.
Intact endothelial cells actively maintain an antithrombotic surface by secreting prostacyclin and nitric oxide, basically keeping things moving smoothly. But the second that vessel wall is injured, the subendothelial connective tissues, like collagen, are totally exposed. Instantly, the platelets activate. They literally change shape, sending out these sticky pseudopods. This is primary hemostasis. It's driven by vital receptors like GPVI for collagen, physically tethering the platelets to the site of injury so they can aggregate into a temporary plug.
But a platelet plug on its own isn't enough, right? It needs mortar. Now, you might remember those old intrinsic and extrinsic cascades from med school. Well, in vivo blood coagulation actually occurs in 3 distinct, overlapping, cell-based waves. Step 1 is initiation, where tissue factor binds to factor 7A. Now, this generates a tiny, almost negligible amount of thrombin, less than 5%. But that tiny spark triggers step 2, amplification, where platelets and other factors get primed. And that sets the stage for step 3, propagation. This is where the massive thrombin burst happens, converting fibrinogen into that solid fibrin mesh we talked about earlier.
So how do these platelets actually manage to stick to the damaged wall in the first place, especially under the massive shear stress of flowing blood? Enter von Willebrand factor, or VWF. You can think of VWF as giant sticky fishing nets deployed by the endothelium to snag passing platelets. But obviously, you can't just leave massive sticky nets floating around in the bloodstream or you'd clot the whole system. That is exactly why your body produces ADAMTS13. It's an enzyme that acts as molecular scissors. It literally chops up these ultra-large VWF multimers so they do their job locally and then just safely disperse.
Let's apply this. Section 3, Pathology of TTP.
When we contrast the normal pathway with the TTP breakdown, the clinical nightmare makes total sense. In acquired thrombotic thrombocytopenic purpura, the patient's immune system basically goes rogue and pumps out autoantibodies that completely destroy the ADAMTS13 enzyme. Suddenly, your molecular scissors are just gone. Those ultra-large VWF fishing nets are now flowing completely unchecked through the vasculature, blindly ripping platelets right out of circulation and forming massive microthrombi in the smallest vessels of the brain and kidneys. And because all of the patient's platelets are being rapidly consumed by these inappropriate microthrombi, their overall circulating platelet count absolutely tanks. The severe cutaneous bleeding and purpura, those dark purple spots that show up on the skin, are the direct physical manifestation of this systemic lack of free platelets. The patient is clotting up their microvessels, which paradoxically leaves them bleeding into their skin and tissues. So when you're facing refractory TTP in the ICU, like that crashing patient we talked about earlier, here is your targeted therapy blueprint. First, initiate plasma exchange, or PLEX. This physically removes those rogue autoantibodies and replaces the missing ADAMTS13.
If they're still crashing, you deploy Caplacizumab. This is a brilliant targeted therapy that directly binds the A1 domain of VWF, basically shielding the platelets from the sticky nets to instantly halt the microvascular thrombosis. And finally, to actually cure them, you use Rituximab to hunt down and destroy the CD20-positive B cells that are acting as the factory, producing the autoantibodies in the first place.
Next up, Section 4, Pathology of DIC.
We established that normal hemostasis has to be temporally and spatially localized, right? It only happens exactly where the vessel is cut. Disseminated intravascular coagulation, or DIC, however, is a systemic explosion. It's usually a complication of severe, life-threatening disorders like sepsis or major trauma. What happens is widespread endothelial damage completely strips away the protective glycocalyx and triggers a massive systemic release of tissue factor. This sets off the initiation phase of the coagulation cascade everywhere in the body, all at exactly the same time.
And this systemic activation brilliantly answers our opening riddle. Because the coagulation cascade is activated systemically, you get widespread platelet activation and microthrombi clogging up the organs. But here's the catch. Your body only has a finite supply of clotting factors and platelets. DIC is a hyperconsumptive state. That widespread clotting rapidly depletes all your building materials. On top of that, your body panics and triggers secondary hyperfibrinolysis, basically trying to break down the clots, which just makes the bleeding exponentially worse. This is exactly how the patient is simultaneously clotting in their microvasculature while bleeding out systemically.
Now, as a quick, high-yield contrast for your exams, compare DIC to hemophilia. While DIC is a systemic, hyperconsumptive drain of all your factors, hemophilia represents a highly specific, localized failure. Patients with hemophilia A or B have a deficiency in factor VIII or I9. If we look back at our three-wave model, this means they fail in the amplification loop. They get that initial spark, but they just cannot generate the massive thrombin burst required to build the stable fibrin meshwork. So it's a failure of construction, not a consequence of consumption.
Which brings us to Section 5, the expert takeaway. If you only remember one single thing from this explainer, let it be this. The bleeding tendency in these severe states, whether it's TTP or DIC, is deeply, deeply intertwined with hypercoagulation. It's a remarkably delicate scale. Intact endothelial cells are not just passive pipes, they are the active masters of this balance. When that endothelium gets damaged, whether by autoantibodies stripping away ATOM CMTS13 or sepsis-triggering systemic tissue factor release, the entire system spirals into fatal consumption.
I want to leave you with this final, provocative thought to chew on as you study these dense pathways. We have moved so far beyond simple blood transfusions. With advanced immunothrombosis treatments that can shield specific molecular domains and target precise immune cells, we are fundamentally redefining our limits in critical care. We aren't just treating the symptoms of bleeding and clotting anymore, we are literally hacking the microscopic machinery of the blood itself. So what will be the next receptor we can target to stop a crashing patient in their tracks? Keep questioning the underlying mechanisms, trust your physiological foundations, and we'll see you in the next explainer.